Hello, this is Dr. Hamade. I am here with you to bring you the lecture on prenatal diagnostic tests. This is also considered the antepartum fetal assessment module. And this module is really going to cover all those common prenatal diagnostic tests and help you to identify and monitor fetal complications that might crop up during the pregnancy. This is also going to be covered in Chapter 15 in your textbook. So as always, I would love for you to spend some quality time with your required reading as you are learning and preparing for this material. So people have been having babies for a really long time now, and we haven't had a lot of testing previously. It's kind of a new phenomenon to have all of these diagnostic and screening tests that are available during the pregnancy. And I want you to know that none of these tests are required for a healthy pregnancy. Many women will, go throughout their entire pregnancy without any of these diagnostic tests, and they're just fine. So, but these diagnostic tests do help us, particularly in high risk complication pregnancies or high risk pregnancies for complications, to identify some of those babies that might be, having some more trouble, thriving during the pregnancy. Know that all of these tests that I'm going to talk about today do come with some degree of risk. They all require some type of informed consent. And know that the patient's always welcome to decline any or all of these antepartum tests that we have available. There's generally 3 reasons why we would offer antepartum testing during pregnancy. The first reason would be to establish some baseline data. Like, for example, if we want to confirm a pregnancy or, that there's actually a pregnancy inside the uterus, we might be confirming the gestational age of the pregnancy or determining the gestational age of the pregnancy. If she doesn't have good dates, like she doesn't know when her last menstrual period is, the ultrasound might be a good way to determine how pregnant she is or how, the gestational age of her pregnancy. If we suspect that there's more than one fetus in there, that can help us. Some of these diagnostic tests can help us to determine that. They might also help us to, figure out, like I mentioned, that it's an intrauterine pregnancy versus like an ectopic pregnancy or a pregnancy that's outside the uterus. The next reason, so that would be like the first reason why we would do some of these antepartum tests. The next reason would be to detect any congenital anomalies that might be going on with the fetus. That can include something like spina bifida or chromosomal abnormality like Down syndrome. And then finally, we might use some of these tests to monitor a condition that we know is present in the fetus. Like, for example, if we have determined that we've got a fetus that's growing smaller or growing more slowly than normal, we might be monitoring that baby for growth over the course of the pregnancy just to make sure that they're meeting their milestones and, growing appropriately, and that we don't need to change our plan of care for that fetus. There in your textbook, box 15.1 is going to have all the medical indications for fetal assessment for all of these diagnostic tests. Some of the more common indications might include some of the pre-existing maternal conditions that a mom might have, like if she's got pre-existing diabetes, that's going to put her at increased risk in her fetus, at increased risk for complications. A mom with hypertension or, a particular infection, especially like sexually transmitted infections, can lend itself to some issues with the fetus. Genetic screening as well, like if we know that one partner is a carrier for a particular recessive trait and the other partner both has that as well, we would be able to offer some testing for the fetus to see if the fetus is affected by that potential complication. Some of the demographic factors for a pregnant woman might increase the risk for complications for a fetus. For example, if we've got a really young patient or an older woman that's having a baby, that could increase the risk for particular complications. So we might offer more testing based on the patient's age. Poverty can play a role. Race. There are definitely some genetic components that are related to the patient's race that might increase the risk for complications. And then also if they have had insufficient prenatal care, for some women they haven't gotten sufficient prenatal care, so we may need be doing some more aggressive screening to look for complications there. If we have a patient who had a complication in a previous pregnancy, that she may be at risk for developing that same complication again. Like, for example, having a baby that was, larger or smaller than, what's considered within normal limits. That puts her at risk for, having subsequent baby with the same, with the same size discrepancies there. So we might be monitoring her a little bit more closely because of the size of her previous baby. Some congenital anomalies, have a genetic component. So if, she had a baby she had a previous baby with a congenital anomaly, we may be monitoring her a little bit more closely or doing some more assessment, for that respect. Complications in the current pregnancy, obviously that's going to, be an indicator for some additional testing. That might include like too much or too little amniotic fluid or some kind of suspected growth issues, like I mentioned earlier. Something that's, we assess during the pregnancy, just during our routine care. Like, for example, I talked to you guys about fundal height and how we measure fundal height against the symphysis pubis. And at about 20 weeks gestation, it should be at about 20 centimeters in line with the umbilicus. And then the fundal height should continue to grow by about 1 centimeter per week throughout the remainder of the pregnancy. However, if, say we have a patient who comes in at 24 weeks and she's, measuring at 24 centimeters, and then she comes back at her 28-week visit, but she's still only measuring at 24 centimeters, that would be a good indicator of, that would, give us a red flag that we should probably offer some additional screening to check on this fetus to look and see if there's any potential problems. Yeah, and again, like I said, you can go through that box 15.1 and kind of consider some of those medical indications. As you're looking at those, and I really want you to start like putting those boxes together, like thinking about, how these different complications might impact the fetus and why we might want to be offering those additional screening tools for those patients. I also want to mention here that antepartum testing that we're offering for these women, it's a very personal decision. We want to be able to provide the teaching for the different tests that are available and the risks associated with all of those tests, and even the predictive value of some of these tests that I'm going to talk about. Like, some of these tests are truly just screening tests. They tell us that we've got a patient that shows markers for increased risk for different complications, but it doesn't effectively identify or diagnose that condition. So, maybe we've, based on one of the screening tools, it shows that her baby is at increased risk for, chromosomal abnormality. That could put some, increased stress on the patient, to make a decision about, more invasive testing, or, what she's going to do about the pregnancy, or maybe cause her some undue anxiety. Based on those results. So it's important to consider all those factors. Know that all these tests are going to help the parents make some important decisions about the pregnancy. It can also help a family prepare for a baby with a serious complication. So, sometimes it doesn't necessarily mean that, they would terminate the pregnancy or, change their plan about continuing the pregnancy, but it could help them to come to terms with the circumstances, so that maybe they can find some resources to help them, or line up a pediatrician that specializes in that particular condition. So there's lots of different things to think about that from that perspective. It's the job of a nurse to be really supportive, non-judgmental, and being able to provide the resources for the patient and answer their questions, and be patient with them in there. It's also important to remember that none of these tests are going to ensure that or guarantee that we've got a perfect baby. All of these tests are fallible in some degree or another. They don't test for every single potential anomaly that's out there. So we can't. We don't. And even then, there's just so much that's left up to the circumstances of the pregnancy continuing normally, and parenthood is a wild card too. So there's truly no guarantee for what we would call it like a quote unquote perfect baby. Yeah, so it's just important to keep that in mind as we're counseling women about the diagnostic tests the tests that are available. Like I said, as you're studying this material, it's probably best to create a chart. This, I've said that about previous hormone things during the pregnancy, but I think for these diagnostic tests, a chart is a really good way to keep all this information straight. The things that I really want you to know are how the test is done, like what all is involved in the test, why the testing would be indicated. So why we would, recommend or suggest this test, would be appropriate for that patient. Like what risk factors might be an indicator for this test. I would want you to know the gestational age that the test is done. So some of these tests are done early on in the pregnancy. Some of them are done later in the pregnancy for different reasons. Some tests are done both early and later, but for different reasons. So it's important to understand the different reasons at the particular gestational age for why these tests are done. I'm going to go through all of this, so it will hopefully help you to fill out that chart. I want you to know if it's a screening test or a diagnostic test. That's super important because we don't want to be, telling we can give them all this information from a blood test whenever, it's really just a screening test. Benefits and risks of each of these tests should be, you should be able to understand those. The nursing management for each of these tests, some of them are just a blood draw and it's a pretty simple, less invasive test, and some of them require, like the amniocentesis is a really invasive test. So, and requires some additional nursing management and teaching. And you should know all of the components of the patient teaching for each of these particular tests. The tests that we're going to be learning about today in this lecture include ultrasound. Ultrasound is probably the one that you're probably most familiar with, as you're coming into this content. But that can also include, blood flow assessment of the fetus. There's different levels of ultrasound that we're going to be talking about. There are a few maternal blood tests that we're going to talk about, alpha fetoprotein being one and multiple marker screening being the other. We're also going to learn about chorionic villus sampling and amniocentesis, as well as umbilical cord blood sampling. And that's where we are actually testing the blood while the baby's still a fetus. In our last lecture, we talked about cord gases and testing, looking at hypoxia in the baby after the baby's already been born. But we're going to actually be talking about the circumstances that might indicate sampling that umbilical cord blood while the baby is still on the inside. We'll talk about antepartum fetal surveillance. That's going to include a non-stress test, a contraction stress test, and a biophysical profile. And then we'll wrap it up with talking about maternal fetal assessment of movement, which is kind of a less invasive but super important. I guess it's less of a diagnostic tool, but more of an assessment technique that mom can use on her own to monitor the fetal movement. So, that's all the different components that we're going to be talking about today. We're going to start with ultrasound. Again, that's probably the one that you're most familiar with. It's ultrasound. If you're not familiar with it, it's a real-time scan of the uterus and its content, and that's going to that scan is going to include a rapid sequence of fixed images that are going to be displayed on the screen there. So the patient and the provider can be looking at the monitor and seeing that the scan as it's being done. Indications for an ultrasound test during the pregnancy really depend on the gestational age of the fetus. So, whenever I was mentioning, it depends on the gestational age, what we're using it for, this is one of those tests. So, early on in the pregnancy, it can be, or at any time during the pregnancy, I suppose, it can be used to confirm that a patient is pregnant. I talked about that, in the normal pregnancy lecture, we talked about how one of the confirmatory or positive indicators of a pregnancy is being able to visualize the fetus. And if we use the ultrasound and visualize the fetus, we can definitely say that she's pregnant. We can also tell the location with the ultrasound. So they can use the ultrasound and actually tell that the fetus is inside the uterus rather than, sometimes pregnancies can occur outside of the uterus, like in the fallopian tube, or even on the near the ovary or in the abdomen. So we would, want to be able to confirm the location of the pregnancy. The ultrasound can also be used to determine the number of fetuses. So if she's got twins or more on board, then we could, the ultrasound can be used for that. It can evaluate the anatomy of the fetus. So we can do a screening test to kind of look, what they call that an anatomy scan, where they're actually looking at all the major parts of the fetus and making sure everything looks normal. An early ultrasound can also tell us about the gestational age of the fetus. Early on during the pregnancy, whenever the fetus is really small, most fetuses are going to grow at an expected rate. So whenever they're really little, we can measure the top of the head to the rump. We call it a crown to rump length. And that can give us a general estimate of fetal age. The earlier on in the pregnancy that we do that measurement, the more accurate it's going to be. We can use an ultrasound to look for appropriate growth of the fetus over the course of the pregnancy. We can use it to look at twins and their growth to make sure that they're both growing appropriately. There's not any that one twin isn't getting all the nutrients and the other one is not thriving as much. We can look at the amount of amniotic fluid that's around the fetus. That's a good indicator of fetal well-being, if there's plenty of fluid around the fetus. We can look at the location of the placenta, the position of the umbilical cord, how the umbilical cord is inserted. We can tell fetal presentation. So I've talked about Leopold's maneuver and also doing a vaginal exam that will help us to indicate fetal presentation. But the ultrasound is also a really easy way to tell, which part is coming out first and, how the fetus is positioned inside. Ultrasound can also be used as a guidance tool for other procedures, like whenever we do an amniocentesis or some of those other things, more invasive testing. We could use the ultrasound to tell us to help to guide those procedures. So you remember from our normal pregnancy lecture that during the first trimester, the uterus is really small. It's still inside the pelvic cavity. It doesn't, extend out of the pelvic cavity until the second trimester. So it's really difficult to see much by an abdominal ultrasound. So most of the time in the first trimester, those ultrasounds are going to be transvaginal. In that case, the patient's going to be positioned in a lithotomy position. There's going to be an ultrasound probe rather than the transducer that goes on the abdomen. So it's like a kind of a long probe. There's going to be a disposable cover. It's like a condom that goes on the top of the probe. They use a gel for lubrication, and that also helps with sound wave conduction. That probe is inserted into the vagina, and we can take a look at the fetus that way. Like I mentioned before, ultrasound can be used early on in the pregnancy to estimate gestational age. That's really useful whenever we've got a patient who doesn't have great dates, like she's not her last menstrual period was. Or if we have a patient who, she had, she knows when her last normal menstrual period was, but then she also had, some breakthrough bleeding at some point, in the intermediary. So she's not really sure how pregnant she actually is or, how progressed she is in the pregnancy. And like I mentioned, early on in the pregnancy, the growth of the fetus is relatively consistent, so we can measure that crown to rump length and get a fairly accurate estimation of the gestational age. As the pregnancy progresses and the fetus gets larger, the genetics of that fetus are going to take over a little bit. So some fetuses grow a little bit faster than others, some grow a little bit slower than others. It just makes up for that, or accounts for the range of sizes of babies at birth. They come out at all different sizes, but as the pregnancy progresses, that growth is going to speed up or slow down based on the genetic components there and the nutrition of the baby. But so it's not going to be as accurate later on. That's what I'm really getting at. Earlier on in the pregnancy, it's the crown to rump length is a really good indicator of the size of the fetus. Later on in the pregnancy, it's going to be less reliable. If we've got a patient who's got good dates in the early part of the pregnancy, she knows when her last menstrual period was. For some women, they know exactly when they conceived, especially if there was fertility treatments used, they know exactly whenever the pregnancy occurred. So there's really not any, big indicator for a really early ultrasound like that. They'd usually wait till a little bit later so they can look at the anatomy. This is actually a picture of a 2D ultrasound image, so you can see this fetus here on the screen. You can see the little arm here, little fingers right over here, and this is the head of the fetus here. It's a little bit hard to see, but you know, if you spend any good time with those ultrasounds, you get really good at you know, determining all those fetal parts and what we're looking at there. But anyway, in the latter part of the pregnancy, you know, after that first trimester, we can start using a transabdominal ultrasound because, like I said, the fetus is growing out of the pelvis and we can see a little bit more abdominally. For that abdominal ultrasound, the patient's going to be reclined on the, you know, either like on a table or on a flat surface. A wedge is going to be placed under one hip. I just want to continue to reiterate that if she's going to be reclined, we're going to put a wedge under one hip so that she's not flat on her back. We would apply a water-soluble gel to the abdomen. That's going to allow those ultrasound waves to pass through so that they can pick up those images. And then the sonographer is going to use a transducer right there on the abdomen to scan the fetus. Like I mentioned before, those images are going to be displayed on the screen so the patient and the provider can look at the screen and see the fetus, and you know, anybody that she's brought along can take a peek at the fetus as well. So as far as advantages for ultrasound, they're considered safe. There's been plenty of research like regarding the safety of ultrasound images, and you know, whenever they're used appropriately, it's considered a really safe measure of assessing the fetus. Those abdominal ultrasounds are non-invasive. It just goes right on the abdomen. It's a little more invasive when it's a transvaginal ultrasound. These exams are relatively comfortable. You get immediate results. Some of those machines are even portable, which is great, especially if you're working in a community that doesn't have a whole lot of people, or in a community that doesn't have like a fixed prenatal clinic, like if it's a mobile clinic that sees, like maybe you might see that in a more rural area where they can't really afford an ultrasound, but they can use a portable device to move around. Some of the disadvantages that I want to talk about with ultrasound is it doesn't always identify every structure or anomaly. So you might have a fetus that has an anomaly that the ultrasound, maybe it's a mild anomaly and the ultrasound just doesn't pick it up. It may not even see all the structures. So, and then if a scan isn't done early enough, remember the gestational age estimates might not going to be as accurate. So, you know, especially like after about 30 weeks or so, it's going to get really inaccurate. There's a wide range of gestational ages, and when we're talking about like a preterm fetus versus a term fetus, that can be really important whenever we're thinking about like the gestational age. So ultrasound equipment is really expensive, and those scans can become expensive, especially if she needs multiple scans or she doesn't have good coverage on her insurance. You know, it can cost a lot out of pocket. The findings from those ultrasound exams might indicate that there's an abnormality or some increased risk for an abnormality, and that could cause some additional stress for the patient, maybe even more testing or diagnostic tests. It's not always completely accurate. It's as accurate as the person that's doing the test and the equipment that they have. So. Often couples will use that ultrasound scan for gender determination, but that's not an indicator for ultrasound. So sometimes on the ultrasound, you've got a fetus that's, tucked up a certain way, like, got their legs closed, and they just can't see the genitals of the fetus, so they won't be able to tell it on that ultrasound. But that's not an indicator. Like, we wouldn't have them come back just so we can do an ultrasound to scan for gender. Usually by 20 weeks we can see that on ultrasound, but again, like I said, we're not going to order an ultrasound just to find out if it's a male fetus or a female fetus. It's also important to know that sometimes those parts can be misidentified. Sometimes the ultrasonographer sees something that looks like a penis and it's not, and you get a little bit of a surprise there at the birth. I've definitely been on those births before where the parents were expecting gender and were surprised by the other. So know that it's not completely foolproof. Usually there's an anatomy scan that occurs around 20 weeks gestation. They're going to be doing measurements for growth that make sure the growth is appropriate at that time. They would be looking for any structural anomalies for the fetus. They'd look at all the organs and make sure the organs look normal and that they're developing appropriately. They would also be looking for structural abnormalities, any like kind of defects, like neural tube defects, any type of abdominal wall defects. And you'll learn a lot more about these as we talk about like fetal development. They're going to be looking at the heart and making sure the heart and the chambers of the heart are functioning appropriately. They might be able to see some facial or limb deformities that could be, present on ultrasound as well. When those risk factors are present and the initial screening warrants, she might be like if there are some warning signs of complications, she may be sent for a higher level of ultrasound, like a more in-depth ultrasound, to be looking for more complications. This little image here is a 3D ultrasound image. This is more of a novelty really than a diagnostic tool. They're growing in popularity. I guess in some clinics they use them more exclusively. And you can see why it's more, especially if you compare it to the previous image where it's, kind of this grainy black and white image versus this one that really looks like a real person. I mean, not that they're not a real person, but it looks like, you can see all those features. You can see, whose nose this baby has. And that helps in a lot of respects with bonding and with really like appreciating the concreteness of the pregnancy. Whenever you think about how far we've come with all these diagnostic tools, a couple hundred years ago, there was no way to even tell that you were pregnant until, that you could conclusively say that you were pregnant until, you could really start feeling movement. And, now we can, effectively get an image of a picture of this fetus as they're growing, it's pretty remarkable when you think about it. Like I said, ultrasound is a really important part of prenatal care from an emotional perspective. It can really make a pregnancy feel more real for the patient and for the partner. It can provide some reassurance also, if, especially for those patients who've really struggled to achieve a pregnancy or maintain a pregnancy. Being able to see the images on the screen can really provide some reassurance for them that things are developing and progressing normally. Doppler flow assessment, it's going to be a more specialized component of an ultrasound. It's not a routine test. We use this in pregnancies whenever we're concerned about the blood flow being potentially compromised. If we've got a pregnancy that's complicated by placental insufficiency, this is particularly common with women with hypertension. Sometimes whenever we've got women that are extremely hypertensive, it can cause some constriction of those spiral arteries in the placenta. I think I mentioned that in our last lecture. Those spiral arteries can become constricted, so blood flow can be reduced to the fetus. That can cause restricted growth of the fetus, and some other congenital or acquired anomalies for the fetus. They're not going to get the nutrients and oxygen that they need. So this Doppler blood flow assessment can help to assess for that and help to determine if there is enough blood flow through the arteries in the umbilical vein. So we may be using that, some more specialized flow test for under the ultrasound. We can also use a color Doppler that really helps us to look at the umbilical cord. You can see it in this image here. If you look closely, you can see those. This shows the directional flow of blood through the umbilical cord. You can see those two little red lines as they kind of swirl around this thicker blue line. So I'd venture to guess that blue line there is going to be the umbilical vein, and those red lines there are those the red parts there are going to be the umbilical arteries. It can also identify sometimes a single umbilical artery can be present. So sometimes there are some malformations that can result in an umbilical cord only having one artery. So one vein, one artery instead of one vein, two arteries, which, again, that's, a more high risk situation, and they would evaluate it appropriately. But it can show us the speed of the blood flow to make sure that the fetus is getting adequate blood flow to the baby. It can also look for abnormalities in the heart for the fetus. And it can verify the relationship between those cardiovascular structures. If there's any concern about, the heart and how the blood is pumping through the heart, then they might use this color Doppler image to view that. So we'll move on to some of the maternal blood tests that we can do to screen for different complications. To start with, one of the first tests that we offer is something called an alpha-fetoprotein screening. Alpha-fetoprotein is the primary protein that's present in fetal plasma. And we don't know exactly what it does, but we know that that protein is a good, at normal levels, it's a good indicator that of a structurally intact fetus. So alpha-fetoprotein is going to be excreted in the fetal urine. That fetal urine is what makes up amniotic fluid. We'll talk about that in fetal development, but it's important to know that amniotic fluid is essentially just fetal urine. Some of that alpha-fetoprotein is going to cross over to the placenta and into the maternal circulation. So we can effectively predict some different anomalies based on the amount of alpha-fetoprotein that's present in maternal circulation. So for this test, we're going to be measuring that maternal serum alpha-fetoprotein. Whenever we're talking about that alpha-fetoprotein test, know that there's two different ways that we can measure it. The least invasive way would be by drawing some of mom's blood and seeing how much of that alpha-fetoprotein is present in mom's blood, but they can also test it in the amniotic fluid. So if they were to actually collect some of the amniotic fluid through like an amniocentesis, that would be able to measure that alpha-fetoprotein level as well. Over the course of the pregnancy, the amount of alpha-fetoprotein is going to increase. It increases at a consistent and predictable rate. So, as gestational age increases, that level of alpha-fetoprotein is going to continue to increase. We do offer that maternal serum test, so the maternal blood test. We offer that between 16 and 18 weeks gestation. We use that to screen for the level of AFP, of alpha-fetoprotein in the maternal serum. Again, that's abbreviated AFP, so if you see AFP, that's what I'm talking about. But we use that test to screen for the level of alpha-fetoprotein in the maternal serum. Those maternal levels are compared to the median levels of alpha-fetoprotein in other women of the same gestational age. So it's incredibly important that the dating is correct, because if for example if we suspect that she's 16 weeks pregnant, but she's actually only 12 weeks pregnant, her alpha-fetoprotein levels are going to be off. It's not going to be in the normal range. It's also important to consider that if she has twins on board, two babies are going to produce more alpha-fetoprotein, so those levels are going to be off, and it's not. That test wouldn't be appropriate for twins, because the levels are skewed to an inconsistent range. So this alpha-fetoprotein is only done during the pregnancy of a singleton. So it's only if there's one fetus on board. It's only done between 16 and 18 weeks gestation. Yeah. So you're probably wondering what that alpha-fetoprotein test means, how we interpret that test. Well, if there's an abnormality with the AFP, if we know gestational age is right, we know there's only one fetus, but the alpha-fetoprotein level is off, it's a pretty good indicator that there's some kind of anomaly going on. But remember, it's just a screening test. This is not diagnostic of any particular condition. If you understand where alpha-fetoprotein comes from, it will help you to understand what might cause those levels to be elevated. Because fetuses that have chromosomal abnormalities, they tend to produce an abnormal type of alpha-fetoprotein. That alpha-fetoprotein is a little bit different, so it doesn't get measured in the same way. So though for a child or for a fetus that has a chromosomal abnormality like Down syndrome, any of the trisomies, those levels would be lower for those fetuses. The alpha-fetoprotein level would be lower if there was a chromosomal abnormality. In the case of a high alpha-fetoprotein level, that's usually associated with open neural tube defects or abdominal wall defects. Sometimes if there's an esophageal obstruction, that can cause that. That's because like with an open neural tube defect, especially like anencephaly or spina bifida, all that alpha-fetoprotein that's usually within the fetus is going to be, spilled out into the amniotic fluid. It's going to cause those levels to be a little bit higher. More of that alpha-fetoprotein is going to cross the placenta. It's going to concentrate in the maternal serum, and those levels are going to be elevated. If there's an esophageal obstruction, that can also cause it to be elevated because the amniotic fluid gets recycled. So the kidneys make the amniotic fluid. The fetus urinates that amniotic fluid out into the surrounding area. The fetus is going to swallow that amniotic fluid and it gets recycled. If there's some type of obstruction in the esophagus of the fetus, it's not going to be able to swallow that. So there's going to be more alpha-fetoprotein that's crossing the placenta into the maternal serum, and it's going to be elevating those levels. So a high alpha-fetoprotein is usually associated with some type of structural anomaly. It would be, it's a screening tool, so it's not diagnostic. So we want to do some more investigation to figure out what exactly is going on to cause that. If you look in your book, there's a box, I think it's number 15.2. It's going to show some of those common reasons for an abnormal maternal serum AFP. Like I said, to conduct that test, it's a maternal blood sample. So we just like do a regular blood draw from like a regular serum blood draw. It's done between 16 and 18 weeks. It's compared to like what they did was like many years ago they collected alpha-fetoprotein levels for women across from a lot of different pregnancies, measured those levels and came up with a normal range, just like they do with a lot of those blood tests. But those tests are really specific to being between 16 and 18 weeks gestation. So we would be comparing the patient's results to those standard levels. Any kind of abnormal result, whether it's too much or too little, is going to warrant additional testing, or at least offering additional testing. So we would want to be, talking to our patient about, an abnormal result and what that could potentially mean, and make some, some offers for, additional testing to help to diagnose a particular condition, so that either she can, come to terms with it, or we can make some plans for the pregnancy. As far as advantages for this test, it's simple. It's just a blood draw. It's minimally invasive. Just doing a quick blood draw. It's economical. Doesn't cost very much to do these tests. Insurance often covers it. And early testing is going to allow for more options. So if we can do this test at 16 weeks, we might have some more options for preparing for this baby, or making additional plans for the pregnancy. Disadvantages include it's just a screening test. It's not diagnostic, so we would need additional tests if we really want to figure out what's going on. Sometimes there can be benign conditions that result in an abnormal testing, like because the dates are so specific. An abnormal test can come from poor dating. There is a really narrow window, so 16 to 18 weeks. She's got 2 weeks to really make a decision about that. And then sometimes there are closed neural tube defects, like some types of neural tube defects where they're closed, and that's not going to allow that alpha-fetoprotein to spill out into the amniotic fluid. So they would get a normal maternal serum alpha-fetoprotein, but not, but I have an obvious structural defect for this fetus. So again, this is another one that doesn't guarantee perfect results for a fetus. So we would, want to make sure that we caution the patient on that fact. So remember that high levels of alpha-fetoprotein are typically associated with structural deformities of the fetus. That causes more alpha-fetoprotein to be spilled in the amniotic fluid, and subsequently that elevated alpha-fetoprotein is going to be transferred across the placenta into the maternal serum. So high levels are usually structural anomalies. Low levels of alpha-fetoprotein in the maternal serum are usually linked to chromosomal abnormalities. So that's where the multiple marker test comes in. That multiple marker test adds 2 additional markers that can help to further screen for chromosomal abnormalities. That's trisomy 18 and 21 are the big ones that we traditionally look for with this test. In this test, the blood is collected at the same time. So we would be offering this test at the same time as the maternal serum alpha-fetoproteins, 16 to 18 weeks. And in addition to the alpha-fetoprotein in the maternal serum, we're also looking at the level of human chorionic gonadotropin, as well as unconjugated estriol that is available there in the maternal serum. Again, I don't want you to memorize these numbers because there's a lot of variables involved here. I generally just want you to be aware that this test will help to. It's a little more conclusive, I guess. It's again still a screening test, but it's a little more conclusive and a little more reliable than just that screening test. So, for example, if you have a patient who wants to know who wants the least invasive way to know the most about her fetus potentially, this would be a good option for the patient. But if she didn't want to do further diagnostic testing, that would be okay too. Yeah, but any patient who has a positive result or a result that would, that's outside of normal limits should be offered additional testing. And that would be generally an amniocentesis. That's generally the next step if we've got a positive multiple marker screening test. But before we get to amniocentesis, I want to talk to you about chorionic villus sampling. Those chorionic villi are going to be the tiny little projections in the placental tissue that burrow inside the endometrium. It's, as the fetus is growing and developing, these chorionic villi are actually what go on to form the placenta. These cells are going to originate from fetal cells, so the chromosomal makeup of this, of the chorionic villi are going to be the same as the fetus. So if we're going to take a sample of that chorionic villi. This is going to be a diagnostic test because we're actually testing the chromosomes of those chorionic villi. This test is done at 10 to 13 weeks gestation. This test is diagnostic. It can be used to diagnose chromosomal, metabolic, or DNA abnormalities. That can include things like cystic fibrosis and other kind of genetic anomalies like that. Indications for this test, because this test would be done before the maternal serum alpha-fetoprotein. So this is kind of a more invasive test, but it has to be done a bit earlier in the pregnancy. So you might be wondering what the indications for this test would be. Sometimes if we're doing an ultrasound and we can see some early anomalies on the ultrasound, that might be an indicator for a chorionic villus sampling. If the patient had a previous child with a genetic abnormality and they wanted to, assess, like especially if it, ended in, an anomaly that was not compatible with life, this would be a good test to offer early on in the pregnancy. If this test is done at like 10 to 13 weeks and they can, discover that this is a pregnancy that will not result in a viable birth, then they can make some plans earlier on about that. And we can get into some of that discussion whenever we talk on Tuesday. I hope that I'm making sense with that. I'm trying to be as diplomatic as possible with my language. But, for some patients that would affect their decision to terminate the pregnancy. And we want to offer that to them as early as possible so that they have that information and they can make that decision. If we've got a patient who's a known carrier or has a family history of a genetic condition, that might be a good indicator for this test, particularly if both parents are known carriers. That can, we can actually pull that chromosomal information and look at the makeup of this fetus and determine if this fetus would have that, would be affected by those genetic conditions. If we've got an ultrasound too, that would be another thing. Like I mentioned, if we've got an ultrasound that might show an abnormality that's associated with a genetic condition, we can offer this test early on to, as a diagnostic, indicator of those genetic conditions. Chorionic villus sampling is collected transvaginally. It can be collected transabdominally, but it's usually a transvaginal collection. There's going to be a sample of that chorionic villus sampling that's aspirated through a small needle It could be a catheter too. That they can use a little catheter that's guided by ultrasound. Either way, they're going to use an ultrasound to help them to like isolate the tissue that they're going to be collecting. Then that sample is going to be set off for analysis. Those results take about 48 hours. That's probably a very harrowing 48 hours to have to wait for those important results, but it's relatively quick whenever you're considering what has to be done. In preparation for this particular procedure, we would be monitoring the fetus both during and after the procedure. We're also going to be monitoring maternal vital signs. We should be teaching the patient, as she goes home from this experience, that she should be monitoring for bleed, because this is really, once the procedure's done, we'll monitor for her in the clinic or the outpatient facility for a little bit, and then she'll be able to go home. But she should be monitoring for bleeding, any loss of fluid, any clots or tissue, any signs of infection. That all that teaching is really important. Some of the advantages of chorionic villus sampling include that it can be done early on in the pregnancy, so that can help her to make some decisions about continuing the pregnancy. And those results are really relatively pretty fast, especially whenever you're at some of these other results that can take quite a while. As far as disadvantages, they can be steep. But one of the disadvantages includes a 2.5 risk of miscarriage. So that's relatively high whenever you're talking about 2.5 out of 100. Into miscarriage because of this particular procedure. There's an increased risk of limb reduction defects, meaning that that there's some a complication that causes the limbs of the fetus to be amniotic banding syndrome is what I'm going for here. But know that there's some risk for injury to the fetus. Particularly if it's done early before 10 weeks. Like I mentioned, infection, RH sensitization. We'll talk about blood incompatibilities and how RH sensitization can happen, but in a later lecture we're going to be getting to that. But know that that's a consideration for this particular test. This test is really labor intensive. Once they get the sample, they have to isolate those fetal cells. They have to actually, look at them under a microscope and isolate the fetal cells so that the test can be done. So that makes it really expensive. Not all insurance carriers will cover these tests or cover them, fully. So that can be really cost prohibitive for some families. And again, this test looks for chromosomal things because we're pulling chromosomes of the fetus from that chorionic villus. We're pulling that chromosomal data. So it may not be able to. There's some things that it cannot detect, like structural defects. For example, spina bifida. That's not going to be detected by this test. Like abdominal wall defects, cardiac defects. Those things are not going to be included in this test. So that's an important consideration. It's kind of a riskier test with some good payouts as well, but it's important to consider those factors. This image here is going to show just kind of what that transcervical chorionic villus sampling looks like. And you can see that this image should look really familiar. We talked about this in our last lecture. We talked about that those fetal capillaries that come in and absorb that maternal blood. Remember, this is that intervillus space where the maternal blood gets dumped, and then the oxygen-rich blood gets kind of bathed around these capillaries, and that's where the reuptake of that oxygen and the release of waste gets exchanged here in this area. This is actually what is effectively removed. It's just a very small sample that gets taken or collected and sent off for analysis. I think that's about everything that you need to know about chorionic villus sampling. The next thing that we want to talk about is amniocentesis. Amniocentesis is remarkably similar to chorionic villus sampling. It's done in a very similar way, but the timing of amniocentesis, this is another one of those, like ultrasound, I said that the timing is going to, or like the cause of the test is going to affect the timing, or the timing is going to depend on the purpose. Those are kind of interrelated, considerations there. Like I mentioned before, we're going to offer that maternal serum alpha-fetoprotein in the triple screen at about 16 to 18 weeks gestation. And that could be the first indicator of, some type of anomaly. That could be the first indicator that there's any type of concern about this fetus. By this point, it's going to be too late for the chorionic villus sampling. You'll remember that happens around 10 to 13 weeks. So we can use an amniocentesis. It's too late to collect the chorionic villus, but we can get some amniotic fluid. That amniotic fluid will have some fetal cells in it, so that can help to diagnose both chromosomal and some biochemical abnormalities with the fetus. In the second trimester, like I said, it's usually diagnostic for chromosomal or biochemical abnormalities. This chart here, it's box 15.3 actually. That's going to show some of the common reasons for a second trimester amniocentesis. I think it's worth it to get familiar with those general considerations. Later in the pregnancy, this is where it kind of gets interesting. I find this really fascinating that we can use amniocentesis later in the pregnancy, and that can help us to determine if the fetal lungs are mature enough for extrauterine life. So if one of the factors that is really a consideration for preterm babies is the ability to transfer oxygen in the lungs. The lungs take some time to develop and to be able to function on the outside as lungs. Sorry, I had a little disconnection there. What I was saying there is that whenever we've got a preterm fetus, one of the big considerations for successful life on the outside is the fetal lung maturity. So one of the ways that we can determine how mature the fetal lungs are is to assess the amniotic fluid. If this is particularly helpful if we've got a mom that's got a complication during the pregnancy, and we're trying to decide if the fetal lungs are mature enough to actually induce labor or have a C-section, so that this baby is going to be able to survive outside of the womb. We're specifically looking for a couple of lipoproteins. They're a little bit hard to say, so forgive me as I butcher these terms, but I'm gonna give it my best shot. But these lipoproteins, it's lecithin and sphingomyelin. These lipoproteins are the what make up surfactant. Surfactant is this slippery soap-like substance that's present inside the lungs as the fetus matures. And the job of surfactant is to reduce the surface tension on the lungs, so that whenever the baby exhales, like baby takes a first breath and inhales, when the baby exhales, there's a risk that the alveoli are going to get kind of stuck to each other and they'll get stuck closed. That surfactant is like a slippery substance that helps to prevent it from staying closed. If I love a good analogy. So if you think of the lungs a little bit like saran wrap, whenever you pull it right off the roll, if you wad it up a little bit, it gets stuck to itself. You've probably had this experience if you've ever used saran wrap. That film gets stuck together. But if you took that saran wrap and you gave it a light coating of some dish soap, then you can imagine it would be a little less prone to sticking. You can see that it probably is a little slippery. It's not going to stick as much. Surfactant works the same way in the lungs. That's what surfactant does to the lungs. It reduces that surface tension so that whenever the baby exhales and the alveoli close up a little bit, that they can pop back open and the surface tension is reduced and the lungs can expand again. So let's get back to lipoproteins. The ones that make up surfactant are lecithin and sphingomyelin. And throughout the pregnancy, as the fetus develops, they're going to continue to increase throughout the pregnancy until about 30 weeks. At around 30 weeks, sphingomyelin is going to level off. It's going to kind of hit its peak, but lecithin is going to continue to increase. There's going to still continue to be, elevated. The level of lecithin is going to continue to increase. Eventually, that lecithin is going to increase at a ratio of 2-to-1 over sphingomyelin. So we call that the LS ratio. It's a little easier to say, the lecithin to sphingomyelin ratio. When that lecithin to sphingomyelin ratio is at about 2-to-1, then we can say that there's sufficient surfactant to allow for fetal lung expansion. There are a few different components that we test for, but this is the big thing that we're looking for in an amniocentesis. We're looking at that LS ratio. And an LS ratio of 2 to 1 tells us that there's sufficient surfactant to allow for the fetal lung expansion. So let's say you've got a fetus that's otherwise growing and thriving, but you've got a mom that's sick, or even a fetus that may be showing some signs of compromise but can continue to grow on the inside for a little bit. We're trying to make a decision, like weigh the options of delivering now versus letting that baby continue to mature a little bit more. They can do this amniocentesis later in the pregnancy to see if the fetal lungs are mature enough to support life on the outside. Testing to see if if there's sufficient surfactant really helps to determine the baby's ability to thrive once it's born. We want to give this baby the best chance possible. Know that amniocentesis this is the most common reason why we would do like a later pregnancy amniocentesis is to assess for lung function, but know that we can also do an amniocentesis towards the end of the pregnancy to assess for hemolytic disease whenever there's a blood incompatibility. Again, that's one of the things we're going to get to later, but know that that's also a reason for amniocentesis. Let's see. I've also got an image here. This one comes straight from your book as well. This is, an image of how an amniocentesis is performed. The patient's going to be positioned on her back, supported by pillows, wedged under the hip, just like many of these other procedures that where we need to access the abdominal wall. We're going to be checking maternal vitals, assessing the fetal heart rate. We want to, make sure that the baseline, the fetal heart rate is appropriate. We'll use an ultrasound to locate the fetus and the placenta, and we're going to also be looking for the largest pocket of amniotic fluid. That's going to be the best place to be able to collect some fluid. The skin is going to be prepared with an antiseptic to keep it clean and reduce the risk for infection. We'll also be using a local anesthetic to numb that area up really well because it's a big needle that goes into the abdomen. We'll use a 3 to 4 inch 21 gauge needle to aspirate that fluid. Once they find that, and again, this is all going to be guided with an ultrasound. Once we find that largest pocket of fluid, we're going to aspirate about 1 to 2 milliliters of fluid first. And we'll be discarding that. That will help to reduce any maternal or get rid of any maternal cells that we might have collected on the way in. From then on, we're going to collect about 20 milliliters of amniotic fluid, and that's going to be removed and sent off for analysis. After the procedure, we'll remove the needle, clean it up, and put a little dressing on that, just like a Band-Aid at that area, just to make sure that she doesn't have any bleeding from that area. Then we're going to be monitoring the fetus for about an hour. We will also be monitoring the uterus with a Toco monitor to make sure that she's not, that didn't cause any contractions. We'll be teaching mom once she goes home to monitor for contractions, watch for bleeding, any leaking of fluid, any signs of infection. We'll teach her to avoid strenuous activity for at least 24 hours, and then she can resume normal activity and continue. Moms who have that are Rh negative will need some RhoGAM. Again, blood incompatibilities in a later lecture, but know that this is a potential opportunity for sensitization for moms who are Rh negative. Advantages for amniocentesis is simple, it's safe. The risk for miscarriage with or fetal loss, depending on when it's done, but the risk for fetal loss with an amniocentesis is less than 1%. It's a really good confirmation of fetal lung maturity. It's a reliable method of assessing fetal lung maturity. And again, it's diagnostic for those anomalies. If we're doing a second trimester amniocentesis, it's diagnostic for those tests because it's going to be actually evaluating the chromosomes. Some of the disadvantages, it's diagnostic for those chromosomal abnormalities, but there may be some, some other factors that it doesn't, with some structural anomalies that may not be detected with the amniocentesis. Those results might take up to 2 weeks to get back. So, particularly if we're, making plans about continuing the pregnancy, And also that's a nerve-wracking 2 weeks, especially whenever you consider some of those other tests are back, really quickly, and we're like diagnosing a fetal anomaly that can be really, a tedious, stressful 2 weeks. Results for that LS ratio for the fetal lung maturity are back much quicker than that. Usually that same day or next day, they're going to get those results much faster, which is important because you would want to be able to sort that out quickly. You don't have 2 weeks to wait to see if the fetal lungs were mature. There is a risk for infection. Obviously, it's a very invasive procedure, and again, it doesn't guarantee a perfect baby. None of these tests do. I guess that's a big point to reiterate, that none of these tests are going to guarantee us that we've got a perfect baby. Always go too far, sorry. Percutaneous cord blood sampling, it's another diagnostic test that's really similar to amniocentesis, but this procedure is actually going to be used to collect a sample of the fetal blood for analysis. We would be using this procedure if we need to specifically isolate fetal blood cells. This could help us to diagnose, specific illnesses from blood incompatibilities, acid-base imbalances, infection within the fetus can be determined by this test, and then some specific genetic conditions that specifically require a blood sample can be, determined by this percutaneous blood sample. Prep for this test is a lot like amniocentesis. She's going to be, laid in that same position with a bump under the hip. We'll be monitoring the fetus just like we did with amniocentesis. We would prep her abdomen the same way, with an antiseptic solution and like a numbing medication there. We'd use the ultrasound to guide it, but this is going to be, the target is a little bit smaller. I'm going to switch the slide here just so you can see it. In the case of this percutaneous cord blood sampling, we're actually going to be going into the umbilical cord. Depending on the type of test, they may be, like for acid-based tests, they may want to get, venous blood versus arterial blood from the umbilical cord. But, I really don't need you to know where we're going to go in the cord. The best or the most important information is we're going to go as close to the placenta as we can. Mostly because for stabilization, it's a little more floppy as sorry, I've got my pointer not working here. As you get a little bit further from the placenta, the cord's going to be a little bit harder to stabilize. So this is the most stable place. This is right there, really close to the placenta. We'll use the ultrasound to guide that, to guide the sample collection there. Risks for this procedure are really, again, they're going to be similar to the amniocentesis. All those same risks are going to exist because we're going into the same space. So it's just because it's going into the actual cord, there's an increased risk for trauma to the cord or infection in the cord. So, we would want to be, letting our patients know about that as well. We'd be providing the same similar follow-up teaching post-procedure, like as far as the amniocentesis goes. So, we would be monitoring the baby after the procedure for about an hour or so. Once she goes home, we would tell her to take it easy for the first 24 hours, and then she can resume normal activities after that. Monitor for contractions, monitor for bleeding, signs of infection, all those same things. So that brings us to antepartum fetal surveillance. This is more common. We see these tests in a lot of pregnancies. This is a really, as a labor nurse, they're all very well versed in these types of tests. There are three essential goals of antepartum fetal testing that I want you to be familiar with. The reasons why we would be doing these tests. First of all, it would tell us if this fetus is healthy and thriving, particularly if there's a complication in the pregnancy. These tests would help us to, identify the fetus that's thriving. They would also help the care providers to determine the best course of action if, in management. So maybe if we see a fetus that's not healthy and thriving, we want to get this baby delivered. It might help us to determine if the baby's going to tolerate labor or if we need to go straight to a C-section. Or maybe it's going to tell us that the baby can tolerate it and is doing just fine and the patient can stay pregnant for a while longer. And it also helps to reduce maternal morbidity and mortality for both mom and for fetus. Whenever we can, determine the viability and the well-being of the fetus, we can, make those judgment calls earlier on to avoid emergency complications later. There are 3 types of antepartum fetal surveillance tests that I want you to be familiar with. We're going to start by talking about the non-stress test. Then we'll talk about contraction stress test and the biophysical profile. The non-stress test, that's abbreviated NST. Anytime I would put that on an exam or anything, I would list both NST and non-stress test just to make sure that you're perfectly aware of what I'm talking about. This is going to be the least invasive, and the least diagnostic, but also the least invasive of the 3 tests. What this test looks like, it's looking for fetal heart rate accelerations. And remember from our last discussion, fetal heart rate accelerations indicate that the fetus is neurologically intact, responding appropriately to movement and stimuli, and well oxygenated. So if we've got a fetus that doesn't have good heart rate accelerations, particularly if there's good fetal movement, we'd be suspicious that this fetus might be hypoxic or acidotic. So we'd be wanting to do some more investigation. The non-stress test involves just the fetal monitoring, the same fetal monitoring that we would be using in the hospital for continuous monitoring. It's just that same equipment. We would have the patient seated or reclined. We put those external monitors, so that the fetal monitor low on the abdomen at about the same level as the fetal heart, and that tocometer that measures contractions would be, placed high on the fundus. They would be wrapped around and secured with those elastic bands, just like she would have in the hospital. We would usually give the patient a little button, or some kind of way to mark whenever she feels the fetus moving. She can push that button, and we'll put a little mark on the monitor, just so we can see when the fetus moves. So because whenever the fetus moves, we would anticipate the heart rate to go up too. Results for this non-stress test can either be reactive. A reactive non-stress test requires 2 fetal heart rate accelerations. That can be with or without movement, but we want to see those 2 fetal heart rate accelerations over a 20-minute period. To qualify as an acceleration, they have to be at least 15 beats above the baseline, and it has to last for at least 15 seconds. So just like what we talked about in the intrapartum fetal monitoring, those accelerations, in order to qualify, they need to be at least a 15 by 15. If the fetus doesn't move at any point during that 20-minute strip, they can use that vibroacoustic stimulation. Remember I talked about that little buzzy device, the one that vibrates and buzzes a little bit? We can place that on mom's abdomen just for a few seconds, just to elicit an acceleration. We can also extend that test for up to 40 minutes. That can, allow for, because remember I said in the last discussion that, sometimes fetal sleep cycles happen. They usually last for about 20 minutes. If you happen to catch your fetus in a sleep cycle and it's, it doesn't have those accelerations, that could really lead to a false positive test. So we want to account for that. So we can extend the test for a little bit longer. So again, a reactive test is at least 2 fetal heart rate actions, either with or without fetal movement over that 20-minute period. A non-reactive test, that means that the fetus did not meet the criteria for accelerations within a 40-minute period. So again, in a nutshell, non-stress test is continuous fetal monitoring. It's just the same thing as continuous fetal monitoring in the hospital for up to 20 minutes, maybe extended to 40 minutes if the fetus isn't moving very much in that time. That test is looking for accelerations in the fetal heart rate. So whenever you're studying for this, know that for a non-stress test, we're looking for accelerations in the fetal heart rate and nothing more. Remember from our last lecture that fetal movement should cause an increase in the heart rate. A reactive test means that we've had a fetus that has had at least 2 of those accelerations over that 20-minute period. And that's going to provide some reassurance that that fetus is well oxygenated and it's neurologically intact. A non-reactive non-stress test does not meet that criteria for acceleration. So it could mean that they had 1 acceleration but not a second, or it could mean that they had none at all. If we suspect there's been a sleep cycle, we can extend that test for another 20 minutes. We can also use that vibroacoustic stimulator to elicit a response. If we have a non-reactive, non-stress test, that would warrant further testing. We might consider a contraction stress test or a biophysical profile, which we'll talk about in a minute. And that can help to further evaluate the baby's metabolic status. This image here shows a couple that's participating in a non-stress test. You can see it looks an awful lot like fetal monitoring in the hospital. We've got the patient reclined there. We've got those monitors in place, and the nurse there is explaining, or the nurse or the provider there is explaining, what's going on there. Know that the nurse can interpret. Nurses that are trained in fetal monitoring can interpret non-stress tests. So if labor nursing is it for you, or clinic nursing is where you're going to end up, and you are doing non-stress tests, you can effectively evaluate the fetal monitoring strip, and call it a reactive strip or a non-reactive strip based on your education and experience. Let's see. So this strip here, or this slide here, is going to show two different fetal monitoring slides. You can see this fetal monitoring strip here above, and then there's another one here below. So this gap here in the middle is a line of delineation between those two different slides. So there's two different distinct non-stress tests here. The top one is going to show plenty of fetal heart rate accelerations. You can see those accelerations are present here, and you're welcome to zoom in there and count and make sure they meet the criteria of 15 beats above the baseline and 15 seconds long. But you can see there's multiple of accelerations that are present. And if you look closely, you can see where it's noted that there's fetal movement, like right here. You can see there's fetal movement, and if you were to go straight up at the same time as the fetal movement occurred, you can see that the heart rate increased. Same here, another fetal movement, another increase in the heart rate. So this top strip here, we would consider this to be a reactive non-stress test. This is reassuring. We've got a fetus that's neurologically intact, that's well oxygenated and thriving. This bottom strip is a little bit different. It's a different story here. This would be considered a non-reactive fetal monitoring strip. You can see here that there are some notations of fetal movement, but if you were to look up from those notations of fetal movement, you see that there's no reciprocal acceleration there. This would be considered non-reactive. I don't know that this actually lasts a full 20 minutes. It doesn't look like it lasts a full 20 minutes, but you can get the picture from this little segment here that there's a big difference between a reactive strip and a non-reactive strip. Advantages for non-stress tests include it's not invasive, and just a monitor that goes on the abdomen. It's painless. It's pretty comfortable for the patient. Low risk for mom and fetus. It's the primary means of testing for patients who are increased risk for uteroplacental insufficiency or concerns about acidosis of the baby, because accelerations are one of the first things that disappear whenever we start to see a baby that's compromised. And because we're not doing anything to stress this kiddo out, we're just taking a snapshot of what the heart rate looks like. This is a really great place to start. This non-stress test can be repeated weekly. Those results are immediately available. We can see them in real time, and the nurse can interpret them, as soon as the test is done. Some of the disadvantages include a high false positive rate. Sometimes, we catch the baby in a sleep cycle and we don't get those movements, or, and that can lend itself to a high false positive rate. And that can cause some unnecessary testing. So maybe we're going to be doing some additional tests that can cause some anxiety, particularly for, in those last few weeks of pregnancy, whenever you've already got a mom who's maybe not sleeping so great and a little bit anxious and concerned about the labor experience. She was high risk enough in order to warrant this test. So that can, having an abnormal result can be really, anxiety inducing for patients. It's also really important to remember that those neurological changes that cause those accelerations aren't present in the fetus before 32 weeks. So sometime around 32 weeks gestation, the fetus starts to develop the ability to increase the heart rate with movement. So if we're doing this non-stress test before 32 weeks, we're not going to see those 15 by 15 accelerations. So, we have to wait until it's appropriate gestational age-wise to be doing these tests in the first place. The next test that I want to talk to you about is the contraction test. Contraction stress test. I would abbreviate that as CST, but again, anytime I would use it, I would be putting, for like exam purposes, I would be saying contraction stress test and CST. That can be done for a non-reactive, in response to a non-reactive, non-stress test. We would also maybe consider doing a biophysical profile, which is the next one I'm going to talk about. But this contraction stress test is going to show us how the fetus is going to respond to contractions. Remember, there's decreased blood flowing to the fetus that as the uterus contracts, it's going to squeeze the placenta a little bit. There's decreased blood flow into the placenta, and the fetus really has to rely on its reserves in order to make it through the contraction. So we're going to be eliciting some contractions and seeing how the fetus responds to it. The setup for a non-stress test is exactly the same as the setup for the setup for a contraction stress test is exactly the same as the setup for a non-stress test. We would be using the same fetal monitor and the same tokometer. But in the case of a contraction stress test, we're going to need some contractions. So usually we're going to use some IV Pitocin, get some Pitocin in the IV to stimulate those contractions. Because the Pitocin can cause some, there's some risk for complications with that, like overstimulating the uterus. And then, potentially we can really stress our kiddo out, and we would usually do this over in the hospital. So this is not usually something we do in the office. Usually this is a patient who goes to the hospital. So it's a little bit more cumbersome and time consuming. It takes a little bit longer to do this test, but it's a good indicator of, how the baby is going to tolerate labor. For this test, in order for this test to be reliable as an indicator of, reactivity to contractions, we need to have the patient have at least 3 contractions in a 10-minute period. So if she's not contracting enough, it's not going to be a reliable test. Likewise, if she's contracting too much, if we overstimulate her uterus, obviously that's going to cause some undue stress on the fetus. So we don't want to have too many contractions. We need to have enough. So I want you to know that at least 3 contractions are required in a 10-minute period in order to meet the criteria for a contraction stress test. We really need to see how that fetal heart rate is going to respond to that stressful stimuli of the contractions. The result that we're looking for that shows us it's reassuring that this fetus is doing okay and is not going to have any complications would be no late decelerations and no significant variable decelerations. Remember that late and variable decelerations are ominous signs. Those are signs that we've got a fetus that's struggling a little bit more. And if we have a fetus with that, they're going to be, having a little bit more trouble maintaining that heart rate whenever they're under stress. So it's important to be able to, to evaluate it from that perspective. These 2 strips, again, so just like the other one that we looked at earlier, these are going to show 2 different contraction stress tests, and you can see, how they're different. The one on the top, you can see that there aren't any decelerations, no lates, no variable decelerations. The bottom slide here, or the bottom fetal monitoring strip, is a bit of a different story. You can see that with each of these contractions, the fetus is going to have a late deceleration. Again, if you were to put a line through the middle of this contraction, and you can see that the deceleration happens after the contraction happens. This is a fetus that's struggling to stay oxygenated with the contraction. So let's see. Sorry, this is a fetus that doesn't have a lot of reserves. They may not tolerate the stress of labor. The great thing about this contraction stress test, it gives the provider some time to plan. So this is not we don't need to rush back to the OR to have this fetus, but we can maybe plan for a C-section and have some time to have the patient fast and so that she's get an epidural placed and get her really well prepared so we can get this baby delivered. You'll notice that neither one of these fetal monitoring strips show any accelerations, but that's okay because contraction stress tests are not about accelerations. Non-stress test is about accelerations. Contraction stress tests are about decelerations. So keep that in mind as you're studying for this. Some of the advantages for these tests is, again, this contraction stress test is going to follow a non-reactive non-stress test. The contraction stress test is a little bit more reliable. If this test is negative, meaning it was negative for later variable decelerations, we've got a 99% reassurance that the uteroplacental unit can support this fetus for another week. So that's a really good indicator that it's, that we've got a fetus that's going to, be okay for a little bit longer in there. A positive contraction stress test, that means that we are positive for some late or variable decelerations. That can, like I said, it can buy us some time so we can plan for delivery before she goes into labor. Some of the disadvantages are things that I've mentioned already. It's more time consuming. It requires that, a different setting. The patient's got to go over to the hospital. They've got to get, admitted to the hospital. That takes some time. We've got to get the baby on the monitor. They usually do another non-stress test first. And then there's the issue of getting enough contractions. You'll see in that first strip there, the one on top, that it doesn't actually meet the criteria because there aren't actually 3 contractions in that 10-minute period. So, you actually have to meet the criteria, but we don't want to get too many. 3 is just what we need. Anything less than 3 is too few, and anything more than 6 is too many. So we need to be in that sweet spot. A contraction stress test is more expensive because it does require that hospital admission. Even temporarily, it's going to cost more money for the patient, or especially if insurance isn't, is billing them item by item. So, so it's important to remember that as a potential disadvantage. So that brings us to the biophysical profile. Biophysical profile, it's abbreviated BPP. This test is going to use an ultrasound along with a non-stress test. And that is going to look at 5 different components of fetal well-being. Those 5 different components include breathing movements, gross body movements, fetal tone, and the amount of amniotic fluid in addition to that non-stress test. So those are the 5 components that we're looking at there. All of those factors, combined, are going to show the acute and chronic markers of fetal well-being. So it's going to tell us how our fetus is really doing. It's a more comprehensive assessment of the fetal well-being. All of these things are going to be controlled. All of the different factors that I'm talking about there, they're all controlled by the central and autonomic nervous system. And each of those, areas in the central nervous system and the autonomic nervous system are going to respond a little bit differently to hypoxia. So it's really a more comprehensive picture of fetal well-being to use this biophysical profile. So understanding that, again, pathophysiology is so important to understanding how we do these tests. So I want to explain a little bit of the pathophysiology so you can maybe put that together in the biophysical profile. Late decelerations, those are an early and obvious sign of hypoxia. So if we've got late decelerations, again, that's tied to uteroplacental insufficiency. She has a contraction, the fetus doesn't tolerate it, heart rate drops, and it takes a little bit of time for it to get back up to the baseline. Again, that's dependent on having contractions. So if she's not having any contractions, we wouldn't have that indicator. We're going to learn a little bit more about fetal development later in this course. I've got a whole lecture about fetal development, but I want you to be aware of some of the fetal activities that develop earlier in the pregnancy. And the ones that develop earlier are going to be the least affected by oxygen compromise. So the things that develop later are going to be the first to be affected by compromise, and I'll explain that a little bit. I mentioned that reactivity in the heart rate just a few slides ago. I mentioned that reactivity, that acceleration that happens when the baby moves, that starts to occur around 32 weeks gestation. So around 32 weeks, the development of that portion of the autonomic nervous system allows the fetal heart rate to increase whenever the fetus moves. But that's one of the later things to develop in the pregnancy, one of the later, the later developments of the fetus. Whenever we've got a baby that becomes hypoxic, those accelerations are going to be one of the first things that disappear. So Whenever we do a non-stress test and it's non-reactive, that's going to be an early indicator that we might have a fetus that can be compromised. If that hypoxia progresses, those fetal breathing movements, again, that's where the fetus practices breathing, expanding the lungs, and inhaling and exhaling some of that amniotic fluid and fetal lung fluid. If that hypoxia progresses beyond the level of causing the accelerations to disappear, those fetal breathing movements are going to start to slow. The baby's going to start to try and conserve some of its resources, and it's going to stop doing some of those breathing movements. Eventually, the fetus is going to start trying to shunt blood to more of the vital organs to conserve energy. And the baby's not going to be moving as much. So the tone of the muscle tones, the baby's going to appear a little less flexed inside the body. And those movements, like the big bumps and the kicks and the gross body movements that the baby has, those are going to start to diminish as well. So you can see that, as the baby becomes more hypoxic, the pH starts to drop. The oxygenation of the fetus gets compromised. You're seeing more and more of these symptoms. The amniotic fluid index is the next one to go. As the baby is shunting blood to those vital organs to conserve energy and to conserve oxygen for those vital organs as well, there's going to be less blood that's going to the kidneys. Remember, the kidneys are responsible for producing amniotic fluid. That's part of the production process, is the kidneys make that amniotic fluid. And if there's less perfusion to the kidneys, there's going to be less amniotic fluid that gets put out. So there's going to be less fluid around the baby. I want you to know that there's not an established normal amount of amniotic fluid. I don't need you to memorize any specific amounts of fluid, but I want you to be familiar with these terms. Normal amniotic fluid, and just for your own knowledge, if we do an ultrasound scan and we measure the amount of fluid, if we can measure 10 centimeters of fluid around the fetus in different in different quadrants of the abdomen, that's considered normal. Some providers will also just only measure one pocket of fluid, and if they find a pocket that's at least 2 centimeters of fluid, like a 2 square centimeter area of fluid, they would consider that that's like a normal amount of amniotic fluid. Decreased amniotic fluids called oligohydramnios. That's definitely associated with some complications. We'll talk about the function of amniotic fluid and why it's important to have a normal amount, and what that, we'll talk about that as we go forward. But I want you to know that decreased amniotic fluid is called oligohydramnios. And then whenever we have excessive amniotic fluid, we call that hydramnios. It sounds a little bit counterintuitive, but hydramnios is going to be an excessive amount of amniotic fluid. Some older texts might call that, textbooks might call that polyhydramnios, but it's really the same thing. Hydramnios and polyhydramnios mean an excessive amount of amniotic fluid. Again, the criteria for the different amounts of fluid really vary from provider to provider. Different people measure it a little bit differently. There's not a real standard. I can tell you what I rely on is my method, but I really don't want you to get too bogged down in those numbers. Just know that we're looking for a reassuring amount of amniotic fluid around the fetus. So once we've gathered, we're going to use an ultrasound for all of these components: the fetal breathing movements, the tone of the fetus, the amount of amniotic fluid around the baby, the gross fetal movements that the baby is exhibiting. We're using an ultrasound to look for all of those things. Once we've gathered all that data, we're going to assign some point values for each of these components. For example, if we've got for each of these components, you can either have 0 points or 2 points that are assigned for it. Obviously, the higher the score, the better off the fetus is. For example, like I said, a reactive non-stress test, that fetus is going to get 2 points for that. If the fetus has 30 seconds worth of breathing movements, they're going to get 2 points for that. The maximum score on a biophysical profile is 10 out of 10 points. So a fetus with 10 out of 10 is thriving, it's doing well. If you want to look up those, and I think I highly encourage you to review the components of a biophysical profile and how that scoring system goes. Table 15.1 in your textbook is going to give you all of those different components. So please be sure to review that. As far as advantages and limitations, the biophysical profile has some great advantages. It can be done in the clinic, so it doesn't require the hospital visit. So this is one of the reasons why we would typically go to a biophysical profile first. We can do it right there in the clinic if we've got an ultrasound. Those results can be interpreted immediately. We can, automatically get the results of somebody evaluating those things right then and there. It uses a variety of techniques. It's going to, assess hypoxia from, a variety of different assessment measures. So that's going to improve the accuracy of the test. So, it's a well-rounded test from that respect. On the other hand, all those test scores are equally scored, but we do know that some of the factors are going to be more useful than others in predicting hypoxia. So, like I said, the things that disappear first are obvious. Those are going to happen first. Whereas, if we've got a fetus who has low amniotic fluid, obviously that's a more ominous sign because that's an indicator of worsening hypoxia. So, they're not weighted based on the acuity of the symptom. So, if they have it, they've got 2 points. If they don't, then it's 0 points, no matter what the symptom is. So there's also not a firm consensus on any of those, on the reliability of scores that are kind of in the middle. We know that a score of 0 out of 10 is more ominous, and that baby needs to get out. We need to get that baby born. And we also know that a score that's really high, like a 10 out of 10, can reliably predict that we've got a fetus that's maintaining its acid-base level, that's well oxygenated, it's doing well. But there's not a real consensus on what we should do with those middle of the road. Like, what do we do with a score of 5 out of 10? Is that, there's not a hard and fast plan for those middle of the road scores. So, just be aware that, like, the extreme values are really good predictors of fetal well-being, whereas the middle of the road scores are maybe a little trickier to interpret. The last big fetal assessment thing that I want to talk to you about is maternal assessment of fetal movement. This is less a screening tool or diagnostic tool, but more of a maternal assessment. In this method, patients are going to be taught to monitor their fetal movements at home on a daily basis. Different providers are going to use different methods. Sometimes, like some providers will say, start counting fetal movement in the beginning of the day, and as soon as you get to 10, well, that you can check it off for the day. You've got a baby that's moving well. Some providers will say, at the end of the day, I want you to lay down for an hour and, count the fetal movements that you get in an hour. And, you need to achieve a certain number of fetal movements in that time. I genuinely just want you to be familiar with this method as a tool for mom to become familiar with the fetus is having. We want mom to be really familiar with the fetal patterns that the baby has. And we also want her to be comfortable with reporting changes in fetal movement so that we can assess her. Because a lot of these patients are coming, especially in the beginning of the pregnancy, there can be big gaps between prenatal visits, and we really want patients to be comfortable with reporting symptoms, especially as something as important as fetal movement. Advantages of this fetal monitoring is it's non-invasive. There's no invasiveness at all. It's inexpensive. It doesn't cost anything to be monitoring the baby, maybe a little bit of time, but that's important too. It's convenient. She's got her baby right there. Might as well be monitoring the movement of the baby. It encourages the patient to be involved in her own care and autonomous for her own care. Some disadvantages to be aware of is that fetal sleep can be confused with decreased fetal movement. Maternal perception of movement might be inaccurate. It could vary by the time of day. Alcohol and drug use for patients who have, those, substance abuse issues can definitely affect fetal activity. And even, normal medications can affect fetal activity. It's also worth saying that, moms who are pregnant with their first baby, once they feel fetal movement, and that, if they're pregnant for the first time, maybe they don't have a toddler that they're chasing after, and they have more time to focus on that pregnancy, so they may be more in tune with the the pregnancy in that way. It's not a bad thing. It's just, circumstances. Whenever you've had a baby or two, and especially for women that are incredibly busy chasing around their other kids, and she finally gets a moment at 10 o'clock at night to lay down and devote to calculate or checking her fetal kick counts, and she ends up falling asleep 10 minutes in. That can definitely affect the reliability of this method. So it's just an important thing to think about. But we always want to encourage assessment of fetal movement by the mom. It improves like the bonding too, whenever moms are encouraged to watch that fetal movement. When it comes to antepartum testing, patient education is so important. I know I mentioned this in the beginning, but it's worth reiterating again. This is a really great opportunity for the nurse to demonstrate advocacy for her patients. I know that a lot of you have already talked about some different components of patient advocacy, but this is a really important time to, this whole semester, because we're talking about specialty units, is a great time to develop those advocacy skills. Because we are dealing with a vulnerable patient population, we need to ensure that our patient is aware of the testing methods and options that are available for her and her partner. Then we also need to make sure that they're aware of the risks involved with all of those testing options as well. Because abnormal results from screening tests might really lead to recommendations for more invasive diagnostic tests, it's important to spell that out ahead of time for the patient. So, particularly for a patient who's at higher risk for, a particular anomaly, like if, an older patient who is at risk for a baby with a chromosomal abnormality, who wants to do that multiple marker screen, if we would want to be talking to her about what the results test mean, ahead of time, that this is just a screening test. It can tell us, your risk of a complication like that arising for your fetus, and what we would offer if her results came back as elevated. So if we had an elevated risk, we would offer you an amniocentesis, and the amniocentesis has some risks associated with it too. And it's important to spell that, because maybe all of that is too stressful. Sometimes just having all of that information is overwhelming. If it's not going to change your plan for the pregnancy, if she doesn't feel like she needs to adjust to, potentially having a baby with an anomaly or a complication, she's got good support. She's going to keep and raise this baby no matter what. And, she's got, she doesn't feel like she needs to prepare with her pediatrician. Maybe testing for her would be more trouble or more anxiety causing than it's worth. And we, as nurses, it's important to be able to support the patient through whatever decision they make for that. Some women are not comfortable with the realization that those tests show an increased risk, and they're not comfortable with the risk for an amniocentesis. So, we just, and for some women, it might, those results might, suggest that she would terminate the pregnancy or not continue the pregnancy based on the results. There's just such a full range of considerers here. So and the big takeaway from all of that is it's really the nurse's job to offer information, offer options, talk to the patient about risks, benefits, all of the things that I want you to know about those things. It's important to be able to convey that to the patient as well. It's important to convey it without any judgment or bias. It's not our job to make those decisions for our patients. And it's not our job to make any judgment calls about the decisions that the patient makes. That's kind of the big takeaway for that. And that's it. That's going to conclude our lecture on antepartum fetal surveillance. We made it all the way through. We're going to be meeting on Tuesday morning to review and read all these topics, so be prepared for that. I'm looking forward to meeting with you guys. Again, as always, if there's something here that you're struggling with, please reach out and let me know. I'm happy to provide some resources or talk it through with you one-on-one. I will be available on Tuesday. We'll be going through that learning guide. I've got some other resources, some other questions that I found from another resource within this textbook series. Some questions that we can cover on this content to hopefully really reinforce this all for you, so you can help to really like get a good grasp on it. Yeah, but that's all I've got. Have a really great weekend. I hope you enjoyed this information, and I'll be here. Bye.